All right, so why don't we get started? We have maybe about 20 minutes to talk about this. So I think we've all seen this evolution of use of robots. Stefano, how long have you been doing using a robot to do a total knee?
What's the question?
How long have you been using a robot to do a total knee? Sorry to ask you while you're chewing.
No, sorry, we got in June 2022, so a year and a half.
Nader?
About a little over 2 years now.
21?
21. Yeah, I've been doing a little over 2 years, so not only am I the oldest, but apparently I have the most experience.
I think you got a week before me, so.
So let's see.
So, Nader, what makes it so sticky?
What makes what so sticky?
The robot. Why do you keep using it?
Well, like I said, I think for me it's multifactorial. It's I think Keith said something that I think might be a little bit gauche to say in public, but that it's fun. I think that's reasonable. I think it's good for fellow education to understand how manipulating variables in knee replacement surgery is going to help balance the knee. And I do see future in technology in general, and it's good to stay relevant.
So I think, like I said earlier, we're just at the beginning of this journey, and I think one of the things I've found is the more comfortable I get with the robot, the more questions I start developing, and I think we have a long way to go before we actually know the answer to some of these things. But what I'd like to do is encourage the audience. You don't actually have to stand up and go to a microphone. You can shout out a question. I can repeat it. We've talked a little bit about learning curve, and it seems like it's somewhere between 10 and 50, depending on the robot and a lot of other variables. Do you think a robot is something that you can dabble in, use it now and then, or if you're going to use it, you need to use it more consistently? Nader?
I think you absolutely have to use it more consistently. You have to, first of all, just from the investment of capital costs and the investment of the robot itself, I think if you're going to dabble in it, you shouldn't do it. It comes with a lot of heartaches in terms of the learning curve, so people can get frustrated. Unless you're committed, you're dooming yourself to failure. And so why even bother? So I think if you're going to do it, you have to consistently do it. You can pick a patient population and do it in. I'm like, I'm going to do it on this patient profile, and then be consistent with it, because that'll keep you honest in terms of what you're using for and who you're using it on.
And what about, Stefano, advanced imaging? Do you think you have to have advanced imaging, or is the evolution of 2D to 3D going to make it where you won't require that at all? Where's that going, do you think?
Let me take a step back to the learning curve. One of the interesting things about robotic learning curve is that it doesn't impact the outcome of the procedure, right? You know where that implant's going to wind up. It may take you a little while to finesse with the device and getting it work, but the beauty of the outcomes has been documented that it's an excellent result, or it's a result you're expecting all the way through. It's not one of these learning curves where you get 3 of them right, 2 of them wrong, and then you get 4 of them right and 2 of them wrong, and then you get better and better. The outcome is consistent. That's an important difference between the usual problem with learning curves. And in terms of 2D to 3D technology, it's really, really promising. The accuracy of the most recent versions of this is within 0.5 millimeters. The accuracy of a segmentation of a CT scan done with manually is less than that. Done with computer vision is actually probably about as good, if not better. So now we're getting to again, yesterday I was presenting full femur, top to bottom segmentation in less than 2.5 seconds with some of the better NVIDIA GPUs. So we're seeing the ability to segment out metallic components out of a CT scan with great accuracy to the point you can actually discern what implant it is. Crazy. It's going to come. But the problem is you have to do the hip, the knee, and the ankle. and with the current systems. So that's going to be a little tricky.
So we've heard a lot of talks earlier. I mean, obviously these things, there's a capital cost, there's costs of the disposables, and then the debate is the cost justified based on hopefully the improved efficiency outcome? You know, we don't know long-term if this is going to make a difference because we don't have long-term data. Short-term, we have some data that perhaps is a bit divided. So then the question becomes, if you're going to not dabble, you're going to do this on most people, or are you going to do it on everybody? Are you going to use it in your ASC on your Medicare patients where we're seeing our reimbursements decline over time? And so, Nader, do you do Medicare patients in an ASC?
That's a great question. So I think part of my barrier to a larger adoption is cost. So I think that's not an insignificant factor that has to be associated with your decision making of when and who to use it on. And so you have to balance the cost that you have with the reimbursement, and especially if you have ownership in an ASC, that becomes an issue. And then, but more so in a global sense of healthcare, you have to manage the costs, especially in the Medicare population, declining reimbursements for the surgeon. If you are not cost neutral, then you're costing yourself a case. How does that work? There's no prescription here. This is something that you have to reflect on your own special economics and how this is going to affect your special situation, because every situation is going to be different. It's different if you are employed and not RVU based versus if you're RVU based. It's different if you own the ASC. It's different if you're getting reimbursed for the robotic knee versus not. So this is not a thumbs up, thumbs down situation, but it's highly variable. This is a very important consideration when thinking about how and where you're going to use it.
So let me just take a step back a little bit. I started my talk pointing out that we set ourselves a really low threshold for success, and that we have an opportunity to rethink, beginning to end, how we do joint replacement in a way that gets us to a better outcome more consistently, with 90% success rate, being everybody happy with that. Now, that is not just the implants. It's not just the way we put them in. It's a combination of factors. But one of the assumptions we all have is that we haven't solved, as of yet, the implant design and positioning piece to restore normal knee kinematics. We think, again, assumption, that doing so, by being able to be much more precise and having the opportunity to do things we couldn't do before in terms of how we position space, will improve the kinematics of that knee. And by improving the kinematics of that knee, that's as far as we can do as surgeons. The rest, we have to manage the entire patient. That is everything from their weight, their diet, post-op. There's a really great talk by Andrew Wickline. He's really pushing this idea of managing swelling. He has a whole protocol. And it includes things like low-salt diets for the first 3 weeks after surgery, no anticoagulants, only aspirin, no using a tourniquet because they increase edema, and improving the entire episode of care. Of this is only one part. So let's not expect the robot to fix everything, but that piece which has to do with us achieving the optimal position of these components, I think that's within reach.
And I think we have to be realistic. The knee joint's such a complicated joint. I don't care what implant system you're using. It doesn't even come close to reproducing a normal knee joint. I mean, with the hip, we're putting in a ball and socket. With the knee, we have this 4-bar linkage, all this other stuff. So we're starting off in a bit of a handicap situation now.
Could you comment on reimbursement from payers? How frequently do you get extra?
Yeah, great question. So in the Seattle area, essentially never. We tried using different codes. Most of the commercial payers won't. They include it as part of the procedure. So in Seattle, we really don't get reimbursed more for that. I know in some locales people are charging. They have the patient sign an agreement and we'll charge an X amount. I don't think that works in Seattle. So I would say the Pacific Northwest is we don't get paid more for doing robotic.
Yeah, I think I'd echo this down here. I would say that there's one payer, I don't know if it's Blue Cross or Blue Shield, that'll pay for the add-on code. Medicare does not pay for it. It becomes a bit of a a conundrum whether you charge the Medicare patients for the use of the robotics or not, and I just, it doesn't feel good to do that.
We make significantly more Medicare patients than all the other billers combined. Because I actually have this. I'm not sure why you're not getting the upcharge. I think it's $7,000.
There's an upcharge, but that upcharge is not covered by Medicare, so patients have to pay a fee for service, but they have to consent for it prior.
Okay, shift gears slightly. So, I mean, we're talking about multiple things at once. We've been talking about going away from the traditional gold standard neutral mechanical axis, and we've heard a lot of different philosophies about that. I think this paper was referenced where it's coronal plane only. I'll grant you that, Stefano. But if you believe this data, there's only about 15% of people who live in a neutral mechanical axis with a horizontal joint line. So perhaps by taking everybody and putting them all into neutral mechanical axis, you could argue that we're taking 85% of people and putting them someplace they weren't meant to be. And I think, Stefano, do you believe there is a constitutional varus valgus and neutral alignment in the patient population in general?
So that was such a controversial paper, but it got us to think about this as a constitutional issue. If you look at people exactly mechanical alignment, like 0 plus minus 1, it's closer to 2 to 3%, and we've published on that as well. We've done a look at this as well. What I'm found interesting is that we have a tendency to think of the tibia as vertical. So we published a paper looking at the alignment of the tibial mechanical axis, anatomic axis to the floor, and on average, in various knees, it's 4.5 degrees. So if your normal native alignment is at 4 or 5 degrees to the floor, not vertical, when you then take that joint line, it has to be horizontal to the floor. And then you get into this varus concept. What you used to do is you take an x-ray, rotate the cassette underneath the patient's tibia until the tibia is orthogonal to the line of the axis, and take that picture, then put up straight, because that's what we like to see. And then suddenly you had this idea that the tibia is in varus. It's not. It's back where it was. So if you look at that x-ray you showed before, you go back one, at first glance, the AP knee, at first glance, you say, well, that's a pretty neutral knee. But if you actually were, I bet you that that tibial joint line relative to tibial axis, if that's a standing view, is about 3 degrees. So it's about how we perceive these things. But the joint line will always be horizontal to the floor. Within 1 or 2 degrees across all humans, with the exception of very, very varus knees, it's essentially parallel to the floor. And when you change it, when you do a mechanical cut and you measure it, the tibia goes into valgus. Now, Eric and I we're perfect, because I do pure kinematic, he does pure mechanical. So we looked at the impact of that on the ankle. We basically also get the same x-rays. It doesn't seem to change anything. In terms of clinical outcomes, it winds up being pretty consistent.
And so do you find that you're doing less soft tissue releases now using a robot than you were 5 years ago, Nader?
I'm doing less soft tissue releases, but again, I think it's based on your philosophy of how you're using the robot. If you're purely kinematic, maybe you're using that as a substitute. But I still find that I prefer to do my balancing with soft tissues. Again, that's my bias towards the robot use, but I can understand why people are using less. I would say slightly less soft tissue releases.
Okay. So here's the case. Guy with a valgus knee, 62-year-old, he's got some osteophytes and stuff. Let's say you're going to use a robot to balance this knee. What are some of the challenges? What are you going to try and do? So, Nader, we'll start with you.
Yeah, so this is one of those things that's on my graph was probably one of the last things you want to tackle with robotics. So a couple of things that you notice on this knee. Number one, it's very arthrofibrosed, a lot of osteophytes in the back of the knee. The knee doesn't bend to past 90 degrees. So in terms of just the approach is going to be a tough approach. I would do certainly as much resection of all the osteophytes as you can anteriorly and as much as you can on the medial side of the tibia. You are going to struggle getting your registration on the femur, especially posteriorly on the posterior femoral condyle. So I also resect my tibia to get it. My patella to get out of the way. I don't. In these situations, I'm not going to sacrifice doing a quad snip if I don't need to, especially if I'm doing it in a normal mechanical knee. Conventional knee. I'm not going to do it on a robotics knee. I don't think that's appropriate. So
So why wouldn't you do it in a robotics knee?
I would.
Snip?
So if I was not going to do it on a robotic, if I wasn't going to do a quad snip, if I'm doing a manual instrumentation, I'm not going to do it on robotics. So I don't have a problem, and I'm not proud to say that if I can't expose this appropriately, I'm going to convert to just manual instrumentation because I know I can do it manually. So I think the biggest challenge here is your posterior osteophytes and getting through that. And so you certainly have a couple of different strategies. You can try to get the tibia sublux, so you can get the tibial registration done and get a tibial first workflow done, and if you're able to do that, then you can get to the back and resect your femoral osteophytes and be able to get your femoral registration done at that point, and then do the balancing process. And so I think once you've done many of these, you can vary your workflow to be able to accommodate such a complex case, but certainly this is not a case for beginners.
Right. So the reason I showed this case is we'd had our robot about 2 months, so I kind of went, hold my beer, let's try this. When you have that amount of posterior osteophyte and loose bodies, and you do, let's say you're going to do femur first, you do all your planning before you make any cuts, and you really can't get back there to dig all this stuff out. Once you dig all this stuff out of the posterior space, what's going to happen to your extension?
Loosen. Yeah, it's going to loosen up.
And again, I didn't fully appreciate this. I was going to use a revision tibial component just because he's such a big guy, but I got this all done. I thought, oh, this is really good, and he was great. I put in the insert and flexion. I put him into extension. He was just loose, and because that extension space, when you take all that stuff out of the posterior capsule, it loosens your extension space. So fortunately, I had a revision system. I could put distal augments and balance them. But the point of this is be mindful if you're going to do robotic knees, you're doing all your planning before you do anything, and you can't access those kind of posterior osteophytes. You have to think ahead that you have to plan for an extension gap that'll probably open up once you remove all that stuff. Varus knee. Nader, are you going to do this robotically, and are you going to do soft tissue releases or just do functional alignment?
Is it correctable?
Pardon me?
Is it correctable varus formity?
Yeah, not really. I mean, this would not correct to neutral.
So this is different also. This is now on the tibial side. Again, you have a lot of osteophytes. You have patella baja here. It's going to make your exposure quite challenging. In this case, again, patella resection first. The AP is more of a rotated AP, so you don't really appreciate the amount of tibial bone loss they have there, especially posterior tibial bone loss. In this case, you have to be mindful of your deformity and the correction of the deformity, because I'm going to probably undercorrect because with this person, I'm going to do some soft tissue balancing as well.
Stefano, anything different that you do with this as far as robotic?
So when we do our conferences every Wednesday and my extras come up like this, or it says, well, you're going to have a constraint there. I'm like, yeah, we'll have it there, but this will be a CR, robotically assisted knee, and it'll have some flexion extension issues because of soft tissue around the knee, and it's not going to be so, but I don't think I'm going to have too much trouble with this. I just always fear them, and then they just used to remove the osteophytes. The collateral is all still there. They don't stretch. The lateral collateral will now be stretched. I know that, and by the way, that's because we have this idea that lateral collateral goes to the tibia. It goes to the fibula head behind, so it's actually slipped behind. It's still pretty good. You can ask the fellows. It's remarkable how often we don't need anything unusual for knees like this.
Yeah. I don't think
it's pure kinematic, like exactly measured resection. And the flexion gap thing you mentioned around the osteophytes is real, but I think you just said earlier, that's why you do before you cement, you balance it, and then you recut as needed.
Yeah, and one challenge I'd say with this, if you have significant posterior medial wear, it depends on your robotic system. The robot, at least the one I've used, does not recognize a sort of an air ball on the medial side, right? So you have to be mindful there, almost trick it, so that way when you register that you're not taking too much tibial bone to be able to do your reconstruction.
That's great. Ellie. So, Stefano, can you repeat the question?
So
What's the question?
the question is, how do you handle bony resections in the kinematic alignment workflow when there's so much deformity, particularly in the tibial side, particularly in the medial side where you don't know what the reference points are? Fair? Turns out that on the distal femur, in someone like this, there's no cartilage, they're right down to bone, and you need to sort of simply resect 5 millimeters, and you're good. Posterior condyles probably still have a little cartilage. You may be looking to resect a little thicker just to get to the 8.5. Distal femur, posterior tibia. Then you do a proximal tibial cut, that is your provisional cut. Now that's when you're doing without the robot. With the robot, I can test it first. And that cut is not going to try to necessarily go down as far as that medial bone loss, right? Because you don't want to mismatch the femur and the tibia necessarily, and I don't mind having a little gap medially if I need to put cement or screws necessary. And then you remove all the ossifieds and see where you're at. Now, with the new workflow, I can actually test that before I do the cuts and see what will show up and adjust accordingly. It's remarkably accurate when you get down to what you finally get, which was Mike's question earlier. Has anybody published what happens before and after the cuts? I haven't seen it. Maybe you have. I think it's an easy study to do, but it looks pretty good. It's just experience. I think you have to see a few, or I should do some videos of doing this and document it.
Are there any cases, Stefano, that you will plan on a soft tissue sort of release?
No.
So I threw this.
I haven't done a medial collateral ligament release since 2013.
So just to follow up on the question, though, because you talked about measuring the bone cuts, and that's going to predict where you're taking bone out and you're putting metal in to replace it. But then there's also this other part that you're saying that, oh, maybe I'll put a screw over medially.
No, that's a straight up total knee surgery. Like if you don't have a medial bone, you have a choice. You can put an augment there, you can cut below, you can cut more tibia and get down to that plane, or you can support it with a screw in the tibia posteriorly with a little cement as a reinforcement. Right? Those are the three options that we use traditionally. Something like this, you want to start conservative, do the 9 millimeter cut. That's the absolute minimum resection. Let's stop there.
Yeah.
9 millimeters off of the medial side, the lateral side?
Lateral side, in this case, will be almost an airball on the right side, medial side.
Right. And I think what Stefano's saying is that you don't want to cut to the base of that defect. You're going to be putting in a 15 millimeter poly insert. So I honestly didn't think this would correct, but like Stefano said, I removed the osteophytes. I didn't do any medial soft tissue release, left it in a little bit of functional varus, and it worked out without having to do a soft tissue release. So I think the power of any robotic system is the ability to plan before you execute and then check what you've done after you've executed. So I think it's time to move on to the industry sessions. So do people know where they're supposed to go, Derek? And so look at your... Brad? Yeah. Anyway, so look at your badge. All right, so Derek and Jeff, again, I want to echo, thanks so much for putting this meeting on. It's great, wonderful venue. Thanks, everybody, for coming here. So go to the breakout sessions, and then there's a break, and we start back here at 2:30, correct? Perfect. Thanks, all.